Welcome back to Taking Charge of My Cancer podcast, episode 63. Joining me today is a very special guest, Dr. Jennifer Fieber. Dr. Fieber is a clinical assistant professor with the University of Florida Department of Surgery in the UF Division of Surgical Oncology. She obtained her bachelor's degree from Brown University in Providence, Rhode Island, and graduated from Yale School of Medicine in New Haven, Connecticut. She completed her general surgery resident at the University of Pennsylvania in Philadelphia, where she also completed a postdoctoral research fellowship at the Center of Surgery and Health Economics and a surgical education research fellowship through the Association of Surgery Education. Following her resident training, she completed an additional year of comprehensive fellowship training focused on breast surgical oncology and overall breast health. Her clinical focus is on the surgical care of breast cancer and benign breast disease, the assessment and care of high-risk breast cancer patients, and overall breast health. She became interested in breast cancer surgery because she values supporting and advocating for her patients through a difficult diagnosis, helping them understand their disease and making decisions about how to proceed with treatment. She loves to work with a multidisciplinary team to provide the best care available, and she's also fascinated by the fast-moving field of breast cancer care that frequently sees new modalities and treatments that improve survival and quality of life. She's able to provide surgical breast cancer, including breast conservation surgery, nipple and skin sparing mastectomies, modified radical mastectomies, nipple exploration, and axillary surgery, and works closely with the UF Division of Plastic Reconstructive Surgery to provide oncoplastic and reconstructive options for her patients. Her academic interests include outreach, improving access to care, and optimizing patient outcomes. She's a member of the American Society of Breast Surgeons and the American College of Surgeons. So Dr. Fieber, thank you so much for being here with me tonight.
Of course. Thanks for having me.
Absolutely. So tell me, you want to tell us a little bit about your role and you're always planning on doing this?
So my role is a breast surgeon on our multidisciplinary team at the University of Florida. So I see most of the patients sort of as the gatekeeper after a breast cancer diagnosis, and then make a big overarching plan that involves usually medical oncology, physical therapy, radiation oncology, and all the other teams. I make sure the workups are complete. And then I discuss surgical options for management with the patients, often working closely with the plastic surgeons. I was not always planning on doing this. I went to medical school and thought I would be an infectious disease doctor because that's what my dad does. And my mom is actually family medicine, so I thought I was going to go the medicine direction. And then I loved surgery because you get to do pretty quick hands-on solutions to problems. And I enjoyed operating and I enjoyed thinking quickly. So that pushed me to surgery. And then I chose breast surgical oncology because I liked having relationships with my patients and being able to offer various things for care, various options, because often in breast cancer, patients have options of different surgical management and also different medical management, which can all be very safe from a cancer standpoint. So I enjoyed coming up with plans and working with patients on what they wanted, in addition to how to treat their cancer. So that pushed me that direction. And then I've enjoyed breast cancer even in the, 10 years I've been in training and medical school and such, how quickly the outcomes have improved, especially in certain subtypes that have been very difficult to treat traditionally. So it's really fun to have a field that you have big trials and information coming out all the time. Getting published at big conferences and meetings and being able to integrate that into care. I also really appreciate we've started de-escalating some care. And I feel like that's really beneficial to patients also.
Excellent, very good. Would you give us some valuable tips for cancer patients? Will be like something that you feel that will be helpful while they're going through this journey?
So the first thing is accept help when it's offered. If people offer to help, you should take them up on it and not feel guilty about it, because there's a lot going on. And if you can offload a little bit, it's worth it. People really do want to help. Often they don't know how to help. So if you can redirect them or actually ask for what you need, that's something I would really encourage. Two is to pick a team that you really trust, a team that you feel like has your best interest in mind and your overarching plan and goals in mind, and that you feel comfortable contacting with questions or any changes that you have. So that'd be number 2. And then number 3 is breast cancer, especially, is a marathon, not a sprint. There's a lot of components of treatment. It goes up and down and up and down. Sometimes they're very intense and some are much less. But it's still, even some of the most early stage small breast cancers end up being like a 5-year course, or even a lifetime course, even though not necessarily everything is high intensity. So just be prepared to kind of go through the slog of treatment.
That's very good tips. Now, if you have somebody, like some of the audience maybe is new, right? They just got diagnosed with
Mhm.
cancer, or they just find, let's start down, like they just found a lump when they were taking a shower. What will be your advice for them to, what is the first step that they need to do if that happens?
So if you feel something different, or if you notice any changes in your breast, the first thing to do is to call if you have a primary care doctor, or get in a free clinic, or however you need to do it to get imaging. Imaging is basically always the first step for changes in your breast, which will consist of usually a mammogram and an ultrasound, depending on age, but that's pretty standard. And then you'd go from there. The radiologist will recommend additional biopsies if they feel it's necessary, and they'll get you plugged into the system if you need to be.
Okay, and
The
then
biggest thing is not to ignore it and wait and hope it goes away,
exactly.
because it makes things often things that are very, very treatable, much harder to treat.
Exactly. And sometimes, I always advise patients, because they tell me about, so and so have this situation. And sometimes how crazy is the healthcare system, and perhaps they don't have a primary care, or they have, like, my primary care have a wait list of 6 months before I can see them. So sometimes it's like, can they just go ahead and go into, urgent care or something like that, and maybe get plugged in to see a
Mhm.
surgeon like you who does, that will be the window to go through, right? That's like the main door to beginning with, right? So we'll be see you.
Right. The healthcare system has become exceptionally difficult to navigate. There also are often free clinics or resources to get free mammograms. It's more for screening, but they will actually be able to direct you with findings, and also help with the financial side that can be very stressful also and lead to delay in care. Because unfortunately our healthcare system is not necessarily user friendly, and also is not financially easy to navigate.
Okay, yeah, so that's great to know. So yeah, for the audience out there, just always look for an avenue to get into somebody, and then will you just tell them a little bit like, yeah, so they got into the program and you're the first person they see usually, right? So they.
Usually, yeah. They usually see the radiologist first if it's a mammogram finding. And then the radiologists recommend biopsies or following closely, or they may say things are benign. Some things don't show up on imaging that are concerning. So often if it's a palpable finding, something you can feel, or a skin change or something, they'll still have you see us. And then you'd be evaluated by a breast surgeon usually, where we perform our own exam and find out your history and also risk factors for breast cancer, so family history and other risk factors, and then kind of put everything together and come up with a plan.
Okay, perfect. What will be a painful lesson that you learn along the way from your, you can be your own personal going through all this, or can be as well something that you experience with any of your patients.
So I think the hardest thing about, I guess, maybe being a physician, or at least to being a cancer doctor, is that sometimes no matter how hard you try and how much you know and how well you take care of the patient, they may not do well because of their disease. So I feel like it's very grounding to know that, but it's also a really hard lesson that you might do every single thing in your power and it might still not turn out well. It's also motivating for the future of directions of things to study and work on, but it's definitely a hard day or week or month when that happens.
Okay. Yep. I can imagine that. If not, we feel really bad from the rehab standpoint when we see the bad news. I just cannot picture how you guys feel when you're like, oh my God, but what's this is happening, right? I'm doing everything in my power to get you. And the patients do everything that they've been asked of. And you just have these patients who
And
have.
it's just a bad disease. And it's not all that common in breast, but there are just some very aggressive, very hard to treat breast cancers. It's also hard because you usually have a pretty close relationship with the patient and the family. And often the woman is the matriarch of the family. And you just see how hard it hits everybody, not even just the patient. So I think that's probably the most painful lesson in medicine.
Yeah, yeah, agree to that. Um, what is means to advocate for yourself and how can people do that?
What does it mean to advocate for yourself? So it means to ask your questions, to not feel embarrassed. It means that if things are delayed or you feel like you're supposed to be at an appointment and no one's given it to you, to follow up with your team. Again, the healthcare system is difficult currently. So often things that are the plan don't necessarily play out exactly as we want them to. So if you know you're supposed to see a radiation oncologist or a medical oncologist and the appointment just didn't happen for whatever reason, following up and finding out why. Coming to appointments as prepared as you can with what your questions and your concerns are. And then also to speak up when when something doesn't make sense to you or you disagree with it, instead of, deciding to do something different and not talk about it, because often there's multiple directions to go or ways to incorporate things that you want in your care. But we have to know about it to be able to do that.
Yeah, that's very good. And again, like you mentioned before, you don't have to do it alone, right? So let people help you around. Let find the right resources, which I think is one of my other questions will be, is any specific resources that you will recommend the patients to look into it so they can be prepared for those questions to ask you?
So I think resource-wise, the two that I recommend the most, one is the NCCN guidelines. It can be a little much at first because they have documents that are for patients, they're patient resources, but they're like 60 pages long. But if you can break it up in small pieces, it's broken down pretty nicely by categories. The NCCN does the basically standard of care for breast cancer treatment in the United States. So their guidelines are they can be a little hard, the actual guidelines to read, but the patient documents go through the different components of care, what they involve. It's good to have kind of that overview if you can break it down. A website that I also really recommend that's a little easier to digest, although you have to find the different components more, is the American Cancer Society breast cancer information. Those are the two that I would say pretty confidently are updated and easy to get a hold of. They're free and easy to go through. So those are the two I recommend most. I do think there's multiple universities that have good websites, but it's a little more hit or miss.
Yeah, yeah, and that's super important, right? So we want patients to know what's going on with them and what treatments, but we don't want them to go to Dr. Google and find all this info. And sometimes it's
No.
for groups, right?
Yeah, be careful about the blogs.
Yes, yes. Sometimes they're really can be very helpful, but sometimes it's just giving you all the bad experience and knowing that your body is not the same thing that another body, right? Everybody reacts different to different treatments. So it's important to look into those good resources that is more from the medical standpoint and not
Have
something.
as much knowledge as you can without going overboard.
Exactly, exactly. How can people find you?
So the University of Florida website, and then also calling our breast center, which I got the number from my coordinator. It's 352-265-0535.
Perfect.
So,
And I will write that down on the show notes as
and then
well.
also if you're seeing someone in the UF Shan system, any of the primary care doctors or OBGYNs can send referrals over too.
Okay, perfect. Is one question that you wish I will have asked you and you will have answered it?
So the thing that I was thinking was that I wish these are women that don't have breast cancer diagnoses, but that women knew that they should have a risk assessment for their breast cancer risk. And if they have a family history, they might qualify for genetic testing. And that those things breast cancer in the United States is so common anyways. It's up to 14% of women in their lifetime. But the reason women do really well is because of early diagnosis and treatment, and that depends on screening more than anything. And that there are a lot of women walking around that would qualify for increased screening or being followed, but they don't know it because it's not common in our system to do risk assessments. And really, you should start at 25 and repeat every 5 years or every few years if there's a change in your history. Especially as imaging is changing dramatically to start to incorporate things like MRI and things like that. There might be things that make it easier to detect breast cancer earlier in some patients. So that was kind of what I was thinking with that.
That's awesome. Will you maybe elaborate a little bit more about like who is on a high risk? Like if I'm walking around and I'm listening to this, I'll say, oh, how do I know like I can be somebody who can come into these clinics?
So the risk factors I think of most are family history, especially a mother or grandmother, especially a younger diagnosis or bilateral breast cancer or a history of ovarian cancer, or even pancreas cancer also, because it's uncommon in that it can be in males. Also male breast cancer. Those are all reasons to often have genetic testing or screening. You have to run, there's a few more things that you have to put into the kind of calculator. A lot of family members with cancer or frequent breast cancer. We often hear about families that 4 out of 5 sisters have breast cancer and things like that. That's obviously concerning. Other risk factors, there's one that's a little controversial right now, but breast density. Very dense breasts tend to have a higher rate of breast cancer somewhat, but also a higher rate of being hard to see. So misdiagnosis. So that's another field. Some places do MRIs on where I trained at University of Pennsylvania, where we recommended MRIs for very dense breasts pretty often. It's not the standard of care at this time, but the combination of dense breasts plus family history definitely can push you that way. And some of the new risk calculators take into account breast density, and that also can be helpful for figuring out risk and additional screening recommendations.
Okay, that's very good to know because you know you hear a lot. This even happened to myself, right? Like I just went
Yeah,
mammogram last week, and then it's like, okay, you have a very dense breast. So
right. And a third of women have dense to very dense breasts, so it's normal.
exactly. So it's like, okay, so it will be, you know, and they are really specific, right? Like they don't have, you don't have any signs of any malignancy,
Right,
but we know as well that it's hard to see small masses in a
right.
cancer. So you're like, okay, so I just go to the Mercy and in a one
So
year
now what? Yeah.
mammogram and then wait and hopefully nothing has happened the next year. Or this like how do you categorize that? Like dense breast to know, oh, I bet just maybe just do an MRI if it's no family history.
There's no family history, so it depends where you are right now, because of insurance company or insurance coverage and also the actual the legislation based on breast density, because some states actually require the coverage of MRIs with very dense breasts. There's the data about how well MRIs cover things compared to mammogram is a little bit controversial because all the big studies are all based on mammogram. But there's definitely a movement towards getting MRI for very dense breast plus family history, or very dense breast plus other risk factors.
Okay.
And possibly there will be for very dense breasts in general. So
Okay.
it's one of those things that's evolving at this point, but definitely some places have shifted more than others.
You know what? Just remind me of something. How do you follow up with patients who had a full mastectomy, right? Sometimes patients are like, well, I have my mastectomy and now what? How do I know nothing else is recurrence, right?
So after a mastectomy, without reconstruction, we follow with physical exam. We look for any changes. We do not get at this time any kind of imaging after a simple mastectomy. If the patients have reconstruction, often to monitor the reconstruction, they'll get MRIs. Maybe not every year, but they may get MRIs and also ultrasounds. But at this time, for after a mastectomy, we just follow by exam. Usually 6 months, basically every 6 to 8 months for the first 5 years. Well, definitely 2 years, and then it's yearly after that.
Okay.
So that's how we follow as of right now. There's been some things looking at nipple sparing mastectomy and if we should be getting imaging serially or not. I don't promise patients they'll never need imaging again because I'm not sure where things are going to go with this. But I say at this time we don't get follow-up imaging. We just follow closely.
I got you. You know, at one point I wonder how much peace of mind following what some diagnostics will give to these patients, right? Because it's like, well, yeah, how do I know again? I'm sure it's a lot of the fear of this cancer coming back, which happen in a lot of the patients. So it's like, I think that that's sometimes giving that peace of mind, you know, it's not like they can go and do a withdrawal blood to tell them
Right.
something, right? So I wonder if as this evolving, if that will be better for their peace of
If
mind.
patients are like it. Yeah, the only problem is every time we add something in, it takes a little while for the radiologist to catch up. So you're at risk of additional imaging and ultrasounds and possibly biopsies. But we'll see where it ends up. There's definitely some places that image the nipple-sparing mastectomies at least. But it's not the standard of care. Physical exam is the standard of care.
Okay, and the last question, that I know you're busy and gotta go, but what is the standard of care with contralateral mastectomies at this point?
So contralateral mastectomy in general, the ASBRS does not recommend, and the SSO. So those are big overarching surgical oncology groups. Do not recommend contralateral mastectomy for risk reduction in most patients. I definitely don't recommend it in patients that have advanced disease or high risk of surgical complications, because when you do a contralateral mastectomy, you double your risk of complications, which can become quite high, like in the 60+% range. It's not shown to improve survival, except for maybe in BRCA. So it doesn't have a survival benefit. It does sometimes give patients a peace of mind. So it's a little bit one of those things I go back and forth about. In general, I don't recommend over the age of 55, as the data really doesn't support it. And I do recommend in cases of BRCA or high risk mutations, or if there's a findings on the other breast that we work up and they're kind of atypia and things like that, that is something else that sometimes pushes me more towards it. But in general, I discourage doing contralateral prophylactic mastectomy.
So you can say to the patient, this is not what I'm recommending. Can the patient say, but I want you to do it?
It depends.
Okay.
It depends on the whole picture. So if they have really advanced breast cancer, and I think we really need to focus on their breast cancer, their current cancer, what I'll do is say, let's wait a year, get you through this big hump in treatment and see how you feel about it at that time. I would say women over 70, I really try not to do it, because you're just buying a lot of complications, and you really aren't decreasing their risk of contralateral breast cancer very much. So those patients in general, now if they've had 6 biopsies on the other side or something like that, then I can maybe be convinced. Patients with a lot of comorbidities, patients that have had heart attacks or on dialysis or things like that, I really don't encourage, because the complication rates are high and surgery is so hard on their bodies, and there's minimal advantage. I would say in general, young women in their 30s with breast cancer and things like 30s, 40s, that really want to have bilateral mastectomies, there's more of an advantage because you have so many more years to have a problem.
Yeah.
And also they tend to be a little bit healthier, so easier to get over surgery. But I would say I definitely over 55 try to avoid.
I got you. Okay, perfect. And I think that being young as well is the symmetry, right? The body imagine, that not that it's not important after 55, because it's
No, not at all. It's just the risk of additional cancers is lower. It's got nothing to do with like how much you want them to, how well you want them to do. Actually, the patients do the same with or without it. But patients actually do better without it after a certain age. Definitely over 70, probably over 55.
Okay. And I know that reconstruction is such a personal, but if somebody asks you, would you recommend, if I'm young, would you recommend breast reconstruction?
So I, in general, feel like you should know all your options. So it's worth meeting with a plastic surgeon to discuss. But I think if patients don't want to have reconstruction, that's absolutely fine. There's pluses and minuses to with or without reconstruction. And I think that that's one of the decisions that's really 100% up to the patient. There's nothing from a cancer standpoint that is going to push me towards or against, unless the skin's affected or something like that, and you can't offer it. Even then, you can offer delayed reconstruction. So I think that both of those questions are sort of on a case-by-case basis. I do encourage most women to meet with plastic surgery just to talk about it, but not because they have to. But if they don't want to and they're sure they don't want reconstruction, then that's fine.
Yeah, I agree.
And I
Yeah.
think patients are happy with whichever decision they make. So,
Okay. I know has been some studies talking about postmenopausal PR positive with high BMI having a greater risk for breast cancer recurrence. How much and what is your intake on that, or will you give us a little bit more information on that?
so I think that obesity is a risk factor for breast cancer and breast cancer recurrence, likely because of the increased exposure to estrogen in your body. So healthy weight, exercise, even if you're not a healthy weight actually has been shown to be beneficial. But in general, working to be as healthy as you possibly can be, I think is definitely worth it. For many reasons, not just the advantages for breast cancer risk, but for overall health and cardiovascular risk and everything involved. Also, if you do get breast cancer, being at a healthy BMI often has a lower rate of complications from various treatments. So I would encourage trying your hardest to get to a healthy weight, although it can be very hard to actually do.
Yeah, yeah. And then it's funny, I just heard this morning something about which kind of like made me wanted to ask you this. When we were talking in our tumor board, talking one, I know one of the plastic surgeons was like, how long ago did she quit the smoking? And that was
Oh
kind of
yeah, that's
back
my
of my
trial.
head. And I was like, oh wait, like what is actually a good time for free
Yeah.
smoking for this
So I
patient?
actually got have a trial with University of Florida. I don't know if you that we're working on making the protocol for, but we don't offer, most places don't offer reconstruction or oncoplastics to patients that are actively using nicotine products. And the reason being that the complication rates just become overwhelmingly high. The complication rates without reconstruction are still much higher.
Yeah.
Ideally, a patient quits using a nicotine product within 4 weeks of surgery, although there's some evidence within 2 weeks is still advantageous. So we're actually doing a trial trying to help patients quit quickly, even if it's temporary, to get to surgery so they have the option of reconstruction. So the plastic surgeons here require 4 weeks, and they actually check a blood level to see to make sure that patients have quit using nicotine because it's such a high
Or,
complication rate. Yeah.
or other,
So
or other,
anyways, but yeah, we're trying to provide resources that are breast cancer focused, specific to breast cancer patients. There's been evidence in patients for hernias and other operations that patients can quit quickly with a high amount of motivation. And then the other group of patients are ones that have neoadjuvant, and it's a little bit of a longer course. They can use nicotine replacement and stuff like that. So we're trying to get it so that we're kind of expanding who's eligible for reconstruction. So anyone that wants to have reconstruction can.
okay.
But it's hard with a new cancer diagnosis to also quit using something that tends to be to help cope with things.
Exactly.
So we're trying to figure out a way of adjusting the current smoking cessation protocols to optimize this group specifically.
Oh, that's nice. That's really good to know.
Yeah,
Awesome.
it's
Well,
new.
I can keep picking your brain for hours, right? So much information, but thank you so much for your time and for all this wonderful information that you just shared with me. I really appreciate it.
Of course. Thank you. Thanks for having me again.
Absolutely. You have a great rest of the afternoon, Dr. Fieber.
Thank you. You too.
Bye.